Hello.
Hi there. I think Dr. Casson will be here soon.
Sure. Can I just check if my video is playing okay? That's just the main thing I just wanted to check.
Sure.
So you can see that okay?
Yeah.
And I just want to see if you can hear the audio all right on this next one. Hold on.
Okay. Yeah, great.
Can you hear the
Okay,
audio?
so here we are. We're going to see if we can get across here. So I'm going to come up against the valve.
Yeah, I can hear it quite well.
Okay.
I apologize. Yeah. Dr. Sathanathan, are you on?
I am.
Oh, good. We haven't met. I'm Barry Casson, and I'll be introducing the grand rounds.
Okay.
So we'll give it a few minutes. Do you have a complete hour talk, or how long do you think it'll go?
I think it'll be about 45 minutes and some time for questions at the end.
Okay. All right. So yeah, we'll give it a couple more minutes.
Sounds good.
I like your background.
Well, we live in a beautiful city, so we're fortunate.
Is that a picture of the city, or is that? I guess it must be, because it looks pretty blue out there.
Yeah, it's not my picture, but it's somebody's.
Yeah. No, it looks good.
Afternoon, everyone.
Hey, Jonathan.
How you doing?
Good. I met your father-in-law the other day.
Oh, you've never met him before?
No.
Oh, wow.
Very nice guy.
Sorry?
Very nice guy. Yeah.
Nice.
Whatever.
Well, I have little choice.
All right. I think I'm going to introduce Grand Rounds. So welcome to Grand Rounds. As you can see by the title, Transcatheter Aortic Valve Implantation, Future Perspectives. We have one of the EP cardiologists, Dr. Sathanathan, will be presenting today. So I look forward to this. It's actually quite exciting, especially since some of this work has been done here. So Dr. Sathanathan, please. Thank you for.
Thank you very much. So as Dr. Casson said, I'm one of the cardiologists here at the UBC Division of Cardiology. I'll just make one small correction. I'm not smart enough to be an EP cardiologist, but I'm just I'm an interventional cardiologist, so a simple farmer by trade.
Thank you.
I guess in my context for this talk, I'll be presenting. I'm one of the implanting physicians here, part of the THV team as well. So what I want to share with you today is really some future perspectives as it relates to transcatheter aortic valve implantation, and much of this will be very familiar to experts such as Dr. Leipzig already, who's clearly a leader in all of this, but I hope I can give you some perspective on where this field is going. These are just my disclosures. And I think it goes to, by no surprise, that certainly regardless of what area of medicine you practice in, you will come across patients with severe calcific aortic stenosis. It is the most common valve disease that we encounter, particularly in the developed world. And as our populations continue to age, these procedures are going to become, or patients are going to become more and more frequent and more common, and that you'll certainly encounter them irrespective of what area of medicine you practice in. You know, the current indications, and I'm sure you're all very well aware, for intervening on these patients is based on a combination of symptomatology and echo criteria. The first criteria is patients have to feel symptomatic. So they need to have either shortness of breath or chest pain or reduction in exercise tolerance. Some of them may have syncope when the valve gets really tight. And this is coupled with the echo criteria, which typically in the setting of a ventricle that has normal function would be a gradient of over 4 or a mean gradient of over 40. Now that's traditionally where it's been, but just some areas where this indications are potentially expanding is that there has been some emerging data that maybe even in patients that are asymptomatic, there may be some benefit, but that's still very much in the early vein of scientific questioning, but one area where the field is also going. Now, in terms of the therapeutic options for treating severe calcific aortic stenosis, the modality on the left that you can see with the chest open is really just open surgical aortic valve replacement, which has been the mainstay of therapy for the vast majority of years, up until the early 2000s, when the therapy on the right really came into, was introduced, and over the last certainly 10 years has increased in prominence and utility in the clinical space. So this is transcatheter aortic valve implantation that we're talking about, certainly in Canada and Europe, and in the US, it's TAVR or replacement, and part of that relates to how the procedure is built, but they basically refer to the same thing. And this is a minimally invasive procedure, which is done from the leg, passed up to the heart in a valve that is initially compressed down into within a single little tube, and then either inflated or released and allowed to expand on itself, which is typically the two modes in which the valves are deployed. Now I'll show you a video where we describe how the steps have progressed and advanced, but that's simplistically what is involved. So if we take a step back and look at valves that were used back in the 1960s, initially this was valves such as the Starr-Edwards valves, which were mechanical valves. And you can see this is an old ball and cage style design. You don't see many of these around too much anymore, but really there was a big advent in 1976 with the introduction of the tissue valve. And the real advantage, of course, as I'm sure you're all aware, is that if you have a mechanical valve, it does commit you to long-term anticoagulation, whereas a tissue valve allows you to not require warfarin. And so that was an advance from a surgical perspective. Now, I think where it's important to know where we're going, I feel very strongly it's important to know where we came from. So the next little segment of the talk is going to be a little bit of history. And part of this is because obviously St. Paul's and Vancouver as a group, and there have been many individuals involved, but has played a really pivotal role in the history of this procedure and the introduction of this procedure, not just locally here, but nationally and definitely globally as well. So I'm sure the individual on the left there on the slide is of no surprise to many of you. He's got a few more gray hairs now, but this is a picture of Dr. Webb back in 1996. And Vancouver, amongst many other groups around the world, was working on various in vitro type testing, looking at ways to minimally fix calcific aortic stenosis. So you can see this is some of the early images from that time with some implantations done into porcine models. And certainly just in the corridors of St. Paul's, there were pigs being wheeled up after hours to the cath lab, and some of these deployments were happening back in the 90s and early thousands. So contrary to that, there was also groups in Denmark, and this is Henning Andersen, who's credited with being one of the early pioneers in this space, were writing up papers and doing animal models with regards to this concept of utilizing a percutaneous technique for treating patients with calcific aortic stenosis. But really where the field took off was when the first in human case was performed, and this is by Professor Alain Cribière, who was also the pioneer and introduced the balloon valvuloplasty. If you're not familiar with that, it's basically just a balloon that goes up across the aortic valve to fracture the calcium and allow the valve to open a little bit better. So he was really, did the first in human case back in 2002. And, you know, there's a very interesting talk just as a segue that he gives about the history of TAVI, where he says, you know, this is a concept that he's thought about for over 20 years. And he gives an interesting kind of story about how innovation is perceived by the scientific community, and that if you think of something really radical, people call you an idiot for the first 10 years and say that you're crazy and you're doing something that's harmful for patients. And then he sort of mentions that only in the last 10 years of his career have people called him a pioneer and a genius. And so I think for any innovative approach, it takes a tremendous amount of courage. And I think many of these pioneers had that, to introduce something that's so different from what the status quo is. So this is what the initial procedure looked like, and it's very different from what you're going to see later on in my talk, where I show you what a typical procedure is performed now. You know, suffice to say, it sounds almost crazy now when you think about how they did it, in that they went up the femoral vein. So they're on the right side of the heart now, and then they puncture across from the right atrium to the left atrium, place a wire from the left atrium to the left ventricle, externalize the wire through the aortic valve, and basically the valve system, which you can see on the left system, very rudimentary technology to compare to what we have now, basically has to make a circle in the heart in order to be deployed at the aortic valve. So a challenging approach, but they were successful. And the patient, while had an initial successful procedure, unfortunately had a lot of other comorbidities and did not survive, but it showed that the procedure could be technically done. Where Vancouver made a tremendous difference, and particularly, Dr. Webb and all the other colleagues here, was this concept of doing the valve from the leg and the femoral artery. So this is very familiar to interventional cardiologists in that the femoral artery is where we commonly go to do coronary angiograms. And so the concept was, why not just do the same thing for the valve, or so-called the retrograde approach. So when we mean retrograde approach, basically the catheters are going against the natural flow of the blood. And so that was where this kind of approach was really pioneered, and it's become the standard approach that is used globally around the world for these kind of procedures. And I'll show you what that looks like in a video later on, as I mentioned. Vancouver is also the first place in the world to do a transapical approach. So in patients where the femoral artery is not big enough to accommodate catheters and tubes, because you can imagine that these valves are fairly bulky and require a certain amount of real estate in the femoral artery in order to pass through without causing any damage. If that's not possible, then an alternative is to go through the apex of the heart. And this was really pioneered here in Vancouver, and we still continue to do types of these procedures to this date. And the team and the surgeons here are really quite expert and excellent outcomes from this approach. So this, I just want to share with you, is a little bit of history. This is the first ever successful live case of a TAVI. Now, in interventional cardiology, at most of our meetings, we have a lot of these live cases which are used to disseminate new techniques and show how to do some of these innovative technologies. So you can see this is a case of Dr. Webb transmitting, and he was the first one to do a live case of this type of procedure, and they're trying to cross the valve. If you're not familiar with looking at this, I hope you can see my mouse, or my little hand here, but you can see this area here is where the aortic valve is. And they're trying to cross this valve and they just can't get across. And part of it is just because the equipment was so rudimentary at the time. This is where the valve is, and you'll see as they're crossing here. I just want you to keep this number in mind, the 4 minutes, and just remember that for later on. So here you can see they finally get across, and they're just gonna bring the valve back, and they're just about to inflate this valve soon. So here we go.
Good. Ready with the pacer? Ready, pace.
And I'm not sure if you caught it, but when Dr. Webb crossed the valve, there was actually a round of applause from the audience. And so here you can see a successful deployment, and this was the first ever live case, and you can see a huge round of applause for the valve going up. And so this was really quite a significant step in terms of showing the community what could be done in a minimally invasive way. And then to that end, the Vancouver group, and this is just Dr. Webb himself going around the world showing how to do this procedure. And this has really been a key step to how this procedure has been adopted globally around the world. And these are just many of the sites that he's visited. And also, of course, the program is world famous. And so it's attracted a number of fellows from around the world who, many of them, I think, it's safe to say, have gone on to become leaders and pioneers in the fields themselves. I feel myself very fortunate to have trained through this program, and I think it's certainly led to a number of fantastic colleagues through. Vancouver as a whole has led to a number of world's first, which is the first transcatheter valve program. The first real series of patients came through the Vancouver group. This was the world's first TAVI hybrid OR, so a combination operating room and cath lab. This was the world's first place to have one. And also a number of first procedures were done. The other thing as well, it also spawned new subspecialties such as structural imaging, which was really founded here with respect to the utility of CT, which has become a cornerstone of doing any structural procedure. Here you can see that the other thing that was also well described, and I think one thing that has always been a credit to interventional cardiology is that we're very good about sharing our complications to improve techniques. So you can see that the image on the left is showing a picture of a valve that is embolized. So this valve should not be where it is right now. And it actually kind of had to be dragged around to the descending aorta to be deployed. But the other thing that changed a lot is not only did the procedure get easier and simpler to do in combination with improved techniques and concurrently with improved technology, also the way in which we cared for patients changed quite dramatically. So optimization of the procedure and patient care was key. So firstly, I alluded to the technique and the devices changing. So one thing was steerability or maneuverability of these catheters was difficult. These are very stiff tubes that are hard to maneuver, and that improved. Crossing the valve became easier because they put things such as a nose cone, so a tapered tip to kind of get across these calcific valves. And also our assessment of the arteries became more reproducible and predictable in terms of whether these arteries would be safe for vascular access. And this was really revolutionized by the imaging team here in Vancouver with the use of CT to help show this. In the old days, this would be the kind of approach sometimes, which would be a cut down, certainly unfamiliar approach to someone like myself who's early in their career. But in the early days of TAVR, this was the approach, and certainly it's not something that we do very much at all nowadays. These were kind of some of the early tubes, and basically they became significantly smaller with time, and that made a dramatic reduction in terms of vascular complications, which was initially quite a big problem with this procedure. So here you can see there's just been a dramatic drop over the years in terms of vascular complications, which were as high as 15% at times in the early days. Mortality also had a big reduction as well in terms of 30-day mortality, which, this is historical data that I wanted to share with you because it's impressive to see that even back then where these patients were incredibly high-risk patients, the mortality certainly in the second half of this registry from 2005 to 2008 was really quite impressive at 4.9%. And it showed that even in this really, really sick group of patients, you could still get very good outcomes. Of note, where are we now? So, our outcomes from last year showed a 0.8% 30-day mortality for all procedures, which is quite impressive for compared to anywhere in the world, really, overall. So this traffic light is, what does this mean? Well, basically, this is just alluding to the approach that how research has gone with regards to transcatheter technologies, and particularly with the TAVI. I think one of the reasons that the technology has become so adopted and is that there's always been a commitment to having the technique supported with literature and science and research. And so the nice thing about TAVI, unlike some other technologies in interventional cardiology, is that they were very systematic in how the technology was being tested. So first of all, it was only offered to patients that were very high risk or inoperable. And then once equivalency or success compared to surgery was shown, they then went to intermediate risk, and then they went to kind of essentially an all-comers population. So this is just a series of family of trials that have looked at this, so called the partner studies. And basically, they showed over the last sort of 8 to 10 years that in all these different patient groups, transcatheter technology or TAVI was either equivalent or in some studies superior to traditional surgical aortic valve replacement. And so this has really had a big shift in how indications for this therapy are utilized. And I'll show you the recent ACC-AHA update that came out late last year related to this, because it's changed how we think about indications, which is one of the things that will change in the future. This partner group of studies has spawned a tremendous number of publications, and this is only a small subset of all the different publications that have come out of this space. In addition to that, the people and infrastructure has changed. We were used to have historically think about the procedure just being just a couple of people doing it. And what has evolved with TAVI is that it's really become a team approach. And this concept of the heart team has become a critical part of how any patient being assessed with valvular heart disease is being assessed, regardless of whether they have a percutaneous approach or a surgical approach. And so it involves a multitude of experts, cardiologists, surgeons, physicians, imagers, echocardiographers, geriatricians, etc., just to name a few, and nursing specialists as well. But on the flip side of that, the procedure has become much more simplified. So just by way of comparison, this is a picture from 2007 when Emory was doing some of their early cases, and you can see everyone and their uncle is in the room. But over time, and this is more consistent with what we do now, in 2020, you can see that typically it's just only really one implanting physician, a couple of fellows, and it's a very streamlined procedure, and there's not a whole lot of individuals that need to be in the room, such as the picture on the left. what spawned through all of this is also this patient care process, which has really been a tremendous advance in how the patients are cared for. And this has really been led by the nursing team here in Vancouver, which has shown not only locally, but also the world that, you know, there's a way to do this, this procedure that can be done without having to invest too many resources while still keeping it extremely safe and allowing a high rate of safe next day discharge. So this is what a routine transfemoral day typically looks like for us. So the patients come in on the day of their procedure. They are admitted at that point. They have their TAVI procedure, which is typically done awake, and usually just in, you know, at least half of cases with local anesthesia only. The procedure typically takes from skin to skin about 20 to 30 minutes. They're walking by 4 hours, and most of the time, they go home the next day, which is roughly about 90% of the time. And so you can see that this has been captured in our provincial metrics, which show that certainly the length of stay for our program has gone down to 1 day. So it's just an overnight procedure, essentially. Now, what's been great is that this approach that was helped developed in Vancouver and some other centers across the world as well has been implemented into what is called a minimalist approach. So trying to improve outcomes for patients while doing what is absolutely necessary and not adding on too many layers of complexity to the procedure. You know, Dr. Wood and Dr. Loke have been critical in assessing this approach in multiple different centers around the world, which is the 3M TAVR study. And this approach has now been implemented across many centers, not only in North America, but in Europe and now in Japan and in Australia. So it's really bringing a consistent way in how you care for patients in addition to how you also do the procedure as a separate thing. So here we go. So this is where TAVI's come to now in 2021. And I want you to think about that 4 minutes that occurred, you know, about 15 years ago when Dr. Webb did that first live case. So here he is coming in with a new system. You can see the timer going. So basically the valve is pushed up from the femoral artery and now in the descending aorta. He's just going to come up around the aortic arch here in a minute. You can see that there's a wire placed in the left ventricle, and this wire acts as a rail in order for the valve system to be deployed across the valve, and so that we have a rail to deliver the system. So you can see he's just coming around the arch, and this is what the system looks like. Basically, there's a little wheel that allows you to put a little bit of flex on the catheter. There's a pacemaker in the right ventricle. This is used to rapidly pace the heart so that there's essentially standstill so that we have stable positioning when we deploy the valve. And there's a pigtail catheter, which is essentially just a little tube that injects dye so that we know where our positioning is. So here you can see that now the valve is about to go up here in a second. And it's just being deployed about now. So you can just see from where we were to where we came, the entire procedure has been done in 4 minutes, whereas 15 years ago, it took 4 minutes just to cross the valve. And obviously, you know, Dr. Webb is the master at doing this. And so it's not typically that all of us can do this in 4 minutes, but certainly it is just to show that what can be done now with just the tremendous advancement in technology. So to date, what I wanted to highlight is that really the success of TAVR to me has been a combination of these different factors, which has been a heart team approach, constant commitment to evidence-based trials, a concurrent advancement in the technology, which has all led to dramatic reductions in complications and simplification of the procedure, which has led to widespread adaptation in multiple different jurisdictions and centers. This has led to a significant innovation with a number of different types of commercially available transcatheter valves available now. And it's predicted to rise to more than 200,000 implants annually by 2025. Certainly what you can see is that the number of procedures and interventions done for calcific aortic stenosis has increased in our province. And there hasn't really been a big decline in surgery per se, but this is somewhat historical data. But I suspect there may be a little bit of a shift in the years to come with an increasing number of these patients having TAVI. So where are we going? So I think to date, where the one thing I want to focus predominantly on the top three issues, because these are, I think, some of the primary concerns with regards to TAVI, as we still have a number of unanswered questions. The latter two, the conduction issues and valve thrombosis, I'll address now. One of the issues that can occur when you place a transcatheter valve is, compared to surgeries, that there's a much higher rate of needing a pacemaker. Part of that relates to where the conduction system runs and adjacent to where the aortic annulus is. And so when we put the valve in, you may stretch that area and potentially cause some damage to the conduction system at that point. And so the pacemaker rate, typically now, depending on what platform you use in terms of the type of valve you use, can range between 5 to 15%. But what is evolved a lot is that implantation technique and how we deploy the valve can have a significant impact on these rates. And actually, overall, you can get these conduction rates now, and I think those will continue to improve with time. Something that still remains very much an area of need and further study is this issue of valve thrombosis. It's been shown that sometimes there can be thrombus that forms on these valves, and that's just not limited to transcatheter valves. It can also occur with surgical valves, and now that we've started looking for it, we're seeing it on all sorts of valves. It's unclear what to do with these sometimes, but typically we tend to anticoagulate them, and I think the understanding around this is going to become deeper in the next few years. So first of all, I think I'd like to talk about whether TAVI is going to become the dominant therapy for calcific aortic stenosis. So this is kind of where we're going. I want to show you a little video of a patient that had their TAVI. Dr. Webb did her about 11 years ago. So she's now 11 years down the track from having a TAVI. She was one of the early patients, and actually we did a little study that I'll show you where we went around and followed up all the patients that were still alive to see how their valves were functioning. And so it actually, my wife is also one of the cardiologists here at St. Paul's, so we spent the weekend. It's a little bit of a family adventure driving around, and she would echo them because she's one of the imaging consultants here. So this is what this lady had to say about her TAVI. Hopefully this will play.
How do you feel 10 years after your TAVI procedure?
Well, most of the time, pretty good.
That's great.
You know, I don't have a great deal of energy at my age. How old am I, 99?
102.
102. Oh, God.
That's pretty impressive. So you had your TAVI at 91 years old.
Oh, 102. My God.
I mean, that's just a fantastic video. But, you know, this lady, just to give you some context, you know, she had her TAVI in her 90s. So clearly she would not be somebody that would be offered an operation. By contrast, though, I'm just going to pause this here. By contrast now, I'm sure many of you are aware that Mick Jagger actually had a TAVI done. And he is clearly somebody that would not be considered high risk. But this is where the procedure is going, because we're not really thinking about risk per se anymore. And this is really where the guidelines, the ACC AHA guidelines, have moved to as well as of recently, where they've really gone away from this concept historically, which people were thinking about surgical risk. It's now really gone to a current mindset of anyone over the age of 80 should be offered transcatheter therapy, so TAVI. Anyone between 65 to 80 years old could be offered either therapy, TAVI or SAVR, and this really comes down to a shared decision-making process with both the patient and their care team as well, or heart team. Now, where there seems to be a hard stop is 65, certainly from the American guidelines, where they would recommend having a surgical replacement done, and I think this is very reasonable. What is happening locally for us in our context? I would say that for us, we have a general guideline that between anyone over 75 would generally have a TAVI, and there's a sort of shared decision-making process between 70 and 75. I think that's fairly consistent with most jurisdictions around the world. But now we're sort of thinking a little bit differently in that in these younger patients, you know, regardless of what type of valve you will have, they will fail. Any valve will fail, whether it be surgical or transcatheter valves, if the patient lives long enough, obviously. So now we're starting to think in a different kind of mindset about what second procedure will the patient need. And this is really where the field is going to go. And there's a lot of discussion right now in the transcatheter space, is what should the patient's first procedure be and what should their second procedure be? Should it be surgery first or TAVI second? Should it be TAVI first, TAVI again, and then surgery? So really what it alludes to is that there really needs to be a change in how we refer to how these different procedures are done. And this is something that we're working on in Vancouver as well, which you may hear about. So it then comes to this ever recurring question, which is how long do these transcatheter valves last? We know that we have some data from surgical valves, which some of the early data is somewhat flawed because most of the papers would only look at a metric of reoperation as a guide or definition for valve degeneration. But that's not necessarily the case, because just because you didn't have an operation doesn't mean that your valve was not degenerated. And so there's been an increase in understanding that it's a combination of imaging-based criteria, need for operation, combined also over a temporal assessment and how those metrics change over time. And so I think it's safe to say that most surgical valves would last roughly around 10 years. There's some have been shown to have much better durability. And this, what I'm referring to, is purely tissue valves, not mechanical heart valves, just to clarify. Now, we don't have as much information with regards to transcatheter heart valves, and simply because that's just, the therapy is so new. So the initial procedures that were done, say, for example, in Vancouver in 2005 or 2006, those patients were very, very high risk. And they were dying from other conditions rather than their valve actually wearing out. And so it was hard to really know what the durability was. So this is what we kind of wanted to assess, was we followed up the patients that were done in Vancouver at 10 years and showed that in those that were alive, and of course it's a very selected, biased population, but what we found was that their valve performance was really quite excellent. Now, we've of course sub-selected out the survivors, but it was reassuring to know that even in this very early technology phase of TAVI, the performance of these valves was very acceptable. So what can you do when you don't have robust clinical evidence? And this is an area of interest of mine, which is bench testing. So we can simulate in vitro durability, and this is one type of bench test that we did to look at this question. And so what we can do is that there's certain metrics and societies that look at minimum standards for transcatheter valves before they're brought to market. And basically these valves in the picture here have been open and closed in what is called a high cycle durability tester, hundreds and millions of times. So these two valves have been tested for 25 years equivalency. So it takes about 2.5 years to run this type of testing before we get the results. And what you can see is that you have the transcatheter heart valve on the left and the surgical valve on the right, and they both function equally well when you simulate this out. This testing does not replicate calcification. It cannot do that, but it shows that in terms of where these valves are equipped. There's been some early also follow-up data from groups in Scandinavia that shows that certainly with some THV platforms, they do seem to have pretty good durability out to about 8 years, although overall the numbers are small and we still need more longer-term clinical series. Now, this is another question that needs to be answered in the future as well, is what can you do if transcatheter heart valves fail? And so this is a big question right now and a big unknown. So, of course, if a transcatheter heart valves fail, you could always take it out. That's one option, is surgery. And then also, why not just repeat the TAVI again as well? And these are both potentially viable options, but we're not really sure as a community which the right approach is. Some of the early figures with regards to or outcomes from surgery do not look so great, but part of that is limited by the fact that these patients that are coming back with failed transcatheter valves that then have surgery are very, very high-risk patients. If they were high-risk 10 years ago or 5 years ago, they're even more high-risk now. And so this was a recent multi-center series that showed that the mortality from having surgical explant of these transcatheter valves was as high as 13%, which is pretty high, and the one-year mortality was about 1/4 of the patients that passed away. So why is it so hard? So let's have a look at a video which might describe and show you what that looks like. So you can see that this is one type of transcatheter valve which has a tall frame, so it sits fairly tall in the body, from the aortic valve up to the ascending aorta. And you can just see how adherent it is to remove this valve from the patient's own anatomy. They're carefully doing this, but this is a very challenging operation for cardiac surgeons on some occasions. Some valve platforms are easier than others. And sometimes it increases the complexity of the operation because it doesn't just involve putting in a new surgical aortic valve. Sometimes they have to replace the whole ascending aorta as well and do a root replacement, which can be challenging. So, and this is what these valves look like when they come out on some occasion. So what about just redoing these TAVI valves, so doing another TAVI in TAVI? So this is actually a very interesting case report that was actually published in the New England, which shows a patient of Dr. Webb's that had their TAVI 10 years ago. They had an aortic gradient of 14, which is across the valve, which is very, very acceptable at the time of their initial TAVI procedure. They then came back with failure of that valve. The gradient had increased to about 72. And they were very symptomatic. She had a very calcific aorta, and you can see that just by the amount of calcium that there is on the aorta. And she had another TAVI valve done and had a very good, very similar gradient to what she had 10 years ago and did very, very well. And this is what these kind of procedures look like. So you can see here is a TAVI valve being deployed inside another TAVI valve. And this is another type of TAVI valve, which is a tall frame valve that you can see. And again, another TAVI valve being put inside. Now, there are some technical differences that may impact how we deploy these valves, and some of these valves are very challenging to simply do what is shown here in the picture. But certainly, suffice to say, it's very possible to do this. This is some bench work that we have been doing in Vancouver to look at these concepts and try and understand what the best way to implant these valves in somebody that has a failed transcatheter heart valve. And I think this field is going to continue to evolve, and this procedure will become increasingly more common. One of our fellows from Israel, Dr. Landis, really published two very seminal papers in looking at this particular topic, showing he collected a tremendous amount of work to collect a huge number of cases from many, many centers around the world, and showed that this concept of repeat TAVI, certainly in the series that he showed, was very feasible and very safe to do. And the outcomes were fairly equivalent compared to when we deploy a TAVI inside a failed surgical valve, which is a fairly routine procedure that we do nowadays. And so that's going to increase. There's another question that remains unanswered in that, a lot of these patients, particularly these elderly patients, also have concomitant coronary artery disease. And what do we do about that? So I'm sure many of you are aware from trials such as Courage and Ischemia that stable coronary artery disease can be managed very well with medical therapy and doesn't necessarily require any invasive therapy. But it's not uncommon that when patients come with severe aortic stenosis, they may also have concomitant coronary artery disease. It's hard to really give you a fixed number of how common that is because based on various series, that number can range between 15 to 80% of patients. But certainly it seems to indicate that the older you get, the more common the disease is in terms of coronary disease, and can affect approximately 2/3 of patients as per some of the randomized controlled trials that have been published. In terms of what we do, it's really unknown, and the practice is very heterogeneous across the world in terms of whether you do stenting or not for somebody that's coming for a TAVI procedure. And so these are just common questions that come up in our heart team rounds all the time. This is coronary angiogram of a patient that was discussed at our heart team rounds. If you're not familiar looking at these pictures, you can see this is the left anterior descending. You can see there's a very tight narrowing in the artery in the mid-segment. And similarly in the right coronary artery, there's also a severe stenosis just in the proximal to mid-segment of that vessel. So what do you do? If you ask 5 different people, you'll get 5 different opinions. And this is just another patient just highlighting that same ambiguity. So this is a very exciting initiative. This study is the Complete TAVR study, which is being led by Dr. David Wood. It's a multi-center trial, and it's an exciting time for us in cardiology because it's led to the inception of a new institute, the Center for Cardiovascular Innovation. And it allows us in Vancouver as cardiovascular researchers to run these large multi-center trials. So this is going to be a 100-site study with 4,000 patients comparing complete revascularization with PCI versus medical therapy in patients that have concomitant coronary artery disease that are undergoing transcatheter aortic valve replacement. And it's an exciting, sort of going to be an exciting next few years for us in Vancouver. We've enrolled our first 3 patients, and so it's certainly, we look forward to working on this trial over the next few years. Now, one other concern that has come up is that, is it easy to get into these coronary arteries when you have a transcatheter valve in place? Now, if you can imagine that tall frame valve that I showed you earlier, it may not be easier because it's easy to get a catheter tube through, because essentially it's like a cage that you're going through. And there's been some early studies that have shown that sometimes it's not possible to do an angiogram or a stent procedure when you have these transcatheter valves. It's not common that you're not able to do that, but certainly it is an issue and an area of concern, certainly in the interventional community. You can see here, this is one of these tall frame valves, and access can be challenging. And you can see that the catheter should be over here where the artery is, but they simply cannot get through the frame. Now, I think this is overcome with a proper education and understanding of where these, how these valves function and where the leaflets of the valve sit. And this is going to be a research question for us as well, with a study that we're hoping to run through Vancouver, which is going to look at whether you can reproducibly access these arteries. So I think I might just end there and hopefully leave sufficient time for questioning. But what I hope that I've concluded with you is that the development of TAVI truly has been extremely extraordinary. I mean, interventional cardiology in context as a whole is a pretty young specialty, but certainly TAVI as a whole is just, the growth has been absolutely amazing. But there still are a number of questions and unknowns that remain that still have to be answered. And I hope I've highlighted that to you today. And I'm happy to answer any questions if there are any, or other wiser people such as Dr. Leipzig, who I see there may have wiser words than me.
Thank you for that really wonderful historical as well as up-to-date information on where TAVI sits today. It's really great. I have one question, and then I'll open it up to the group. The present valve, or the valves that exist before, is there any difficulty? Do you ever have embolization of the material from the older valves, or do you remove anything, or does it just stay in situ and is compressed by the newer valve?
Yeah, so that's a very good question. So that relates to embolic phenomenon that can occur when you put the new transcatheter valve in. And so this is an area of debate as well, and an unknown. So there are devices that have been developed. One is called the Sentinel device, and essentially it's a basket that sits up into the great vessels here to prevent little fragments going up to the brain. It's not something that has been shown to be definitively effective. It's not something we use in Vancouver, but certainly is a concern. But the one thing I would say is that when you look at the randomized trials, the stroke rate hovers at less than 1%. So we don't feel that it's a major clinical concern, but certainly stroke can happen during these procedures, but it's not frequent.
Good. So I'll open the questions to the rest of the audience. Jonathan, you were singled out. Do you have any specific comments or questions?
No, I would just commend Janar for the great talk, and it just highlights, I think, the journey that has been taken, and really, you know, with John and David, their vision for the growth of structural interventions and the opportunities that people like myself have had because of all the wonderful fellows that have come over the years that have allowed us to really investigate how to do these things better in these patients that were previously, unable to receive care. And there's many outstanding questions as Janar highlights, but I think that we're really well suited here in Vancouver, especially with CCI now, to really help answer many of these great questions. So it was an excellent overview, Janar. Thank you.
Jonathan, can I ask you a question, and maybe just to get your perspective? I mean, you're a leader in this field, and I think it would be helpful for people to know where you see, from an imaging perspective, the field going with regards to these kind of technologies.
Yeah, I mean,
AI and all these other technologies and heart flow and things. So,
yeah, it's a good question. I don't know how well my camera's actually on me here, but what I would say is, when I started at St. Paul's in 2007, 2008, we didn't even have the ability to do a dedicated cardiac CT. And then in May 2008, I convinced John that we could do this, and David was just finishing his fellowship, and they were tremendously supportive about investigating that we could use CT to help inform decision making around sizing. At the time, of course, there was a reliance on two-dimensional echo, which has obviously come so far as well as it relates to three-dimensional echo and advanced echo imaging. But if you would have told me that we would have come so far with regards to understanding and refining risk based on CT anatomy and that, I wouldn't have necessarily predicted it. So, where we're going to go forward, I think there are opportunities, as you mentioned, around automatic analysis and AI-based segmentations for more reproducible analyses to reduce the time and the cost. I think the integration of things like computational fluid dynamics, as you mentioned, to look at physiology in addition to the anatomy, I think is really exciting. And that's just in the CT and MR world as it relates to predicting risk and refining understanding of who will derive greatest benefit. But then there's, as you know, with our echo colleagues, all the other tremendous opportunities as it relates to strain and better understanding of coexisting conditions like amyloid to better identify patients who should be treated and how they should be treated.
Thanks, Jonathan. Any other questions or comments for?
Stefan here, a very nice talk. I just want to ask about the vascular access. Do you do angiograms in all patients? And is there a risk if you put that catheter through aorta full of atherosclerosis that you will get cholesterol emboli and stuff like that? Now, often do you see that as a problem?
Yeah, so, the vascular access we do is, in terms of complications, major vascular complications, is fairly uncommon now. I mean, it's still one of the more common complications, but I would say that right now it's about 1% is the risk that we quote patients. We've moved to doing the access under ultrasound, which radiology colleagues have been doing for years, but in cardiology has not been commonplace. And I think that's made a big difference for us in terms of getting safe access. The tubes are not so big that we have much interaction with the aorta as we're going up. So the risk of emboli to things such as the kidney are not common. It can happen. And also distal emboli in terms of vascular compromise is also uncommon. Where we get concerned about is as you're bringing the catheter around the arch, we're very conscious to not try and scrape that aorta because that may increase the stroke risk. But overall, those kind of embolic phenomenons are not common, and I would say would be less than 1%.
Any other questions for Janar? Comments? Well, if not, that was really a remarkable presentation. I certainly learned a lot. I remember some of the history, but thank you for refreshing it. And for those leaders, especially John, who just continue to do the good work that he's doing. So thank you very much for the presentation. Next week's Grand Rounds is going to be brought to us by Palliative Care, and it's a host of physicians. And the title is Relationship-Based Models of Care Using a Complex Adaptive System Lens. So a lot of words and probably a very interesting topic. So please join us next week. Thank you again for the wonderful presentation.
Thank you for the opportunity to speak today. Thank you.